Hi, everyone. Welcome to the Sports Docs podcast. On each episode, we chat about the most recent developments in sports medicine with experts from around the country. Today, we're coming to you live from the 10th annual Arthrex Team Physician Controversy course in Naples, Florida. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan. Team Physician Controversies is a 2-day conference highlighting the world orthopedic experts for collegiate and professional sports. We're talking about case-based presentations from diagnosis to care and treatment, all the way to return to play. We're lucky to have experts from our field in the studio today to discuss the latest and greatest in techniques.
We're joined today by Dr. Ned Amendola, a professor of orthopedic surgery and chief of sports medicine at Duke University. He is the current president of AAOS and is a former president of AOSSM. Dr. Amendola also serves as the head team physician and chief medical officer for Duke Athletics. He has extensive experience treating complex foot and ankle injuries, so we're excited to have him join us today. Dr. Amendola, welcome to the show.
Well, thanks for having me.
We're excited you're here. So today we're diving into one of the more nuanced injuries we see in athletes. So the ankle syndesmosis injury or high ankle sprain. Specifically, we're going to focus on the surgical management of this problem. But before we get into the surgical details, we want to start big picture. So what are your indications to proceed for surgery for this type of injury?
Well, basically, if you have instability of the tibiofibular joint or the syndesmosis, which is the crux of the problem, is to assess the instability. So, that injury is a spectrum of severity. The most severe ones where you have, X-ray abnormalities, go to surgery. The very mild ones that the athlete can continue playing and continue using their foot and ankle are mild and they can get by without surgery. It's the ones in the middle that are hard to really figure out who is unstable and who is stable. And that continues to be an area of investigation. So I think we're talking about that athlete that has a high ankle sprain, and it's not mild, it's not severe, and we're kind of in the middle ground. And so I think it takes a lot of clinical acumen, kind of figure out exactly what happened. And the cases that are unstable will require some stabilization to allow them to get back to play on a timely basis.
Great. So let's talk more about that. Let's talk about the surgical stabilization. So we've moved away from rigid screw fixation to more dynamic fixation using that TightRope device. Now, you were one of the earliest adopters of the TightRope device. Can you talk about why you made that move at that time? What gave you the confidence to shift techniques?
Well, when I trained, and even after I trained, we used screw fixation. And when you look at the results of using screws, and I did a literature review where we looked at all the papers written using syndesmosis screws. There's a significant incidence of complications from using the screws. So if you leave the screws in, about 50% of them will fracture. The screw will break because you need normal, a slight amount of normal movement between the tibia and fibula to allow the ankle to function normally. So when an athlete heals, they have no more pain, they start using their ankle normally, they get this toggling, and eventually the screw metal will fail. So that was really kind of the main reason was in these cases that you don't have severe instability and they need some stabilization. I think we could do things better, with something that didn't have those complications. So when the TightRope came out, with the flexible fixation, I thought it made a lot of sense. It answered the problem. This does provide stability, allows it to heal, but then once they go back to sport, it allows a little bit of movement between the tibia and fibula, so it's more physiologic. The athlete has more physiologic motion of the ankle, and they don't have any discomfort.
Great. Yeah, Ned, as you said, the TightRope, it's giving them dynamic stability, but there's also no need for removal of hardware down the line or hardware failure. And we're also seeing faster return to sports. And so it's really great things for our athletic population. But as far as for surgeons considering it, the technique really matters. So I think our listeners oftentimes want to hear the details of your technique in particular. So can you walk us through that?
Well, I tend to do arthroscopy at the time. So in these injuries, again, it's good to kind of understand all the pathology going on in the ankle. So with the high ankle sprain, there's often a shearing of the joint. So I think a certain percentage of the time you have a little bit of a chondral injury or scuffing of the articular cartilage. So you want to assess for that and take care of that at the same time. You can assess the amount of instability. So with the arthroscope, you can see the anterior tib fib ligament, if it's disrupted, which it usually is, and then you can go posteriorly and see if the posterior ligament is disrupted. And then you can assess the deltoid. So you get a complete picture of the injury. And most of these injuries, it's an incomplete syndesmotic injury where you have the anterior ligaments are torn, the interosseous ligaments are torn, and so you have a little bit of movement there, but the posterior one is generally slightly injured or incompletely injured and the deltoid's intact. So you can take care of the syndesmotic injury, period. Or if there's an associated deltoid injury, you can take care of the syndesmotic injury and then take care of the deltoid. And then after the procedure is complete, you can go back in with the scope and assess what you've done, assess your reduction, make sure that everything looks anatomic and that you've achieved the goals of the surgery.
Absolutely.
So you mentioned assessing your reduction. We know that the TightRope has a lower rate of malreduction compared to screws, but we still have to pay attention to that. Any pearls or pitfalls that you tell your trainees to look out for when performing the reduction in terms of clamp position, compression to lessen that risk of malreduction?
No, that's a really good point. So if you have, first of all, if you have mild instability that it can only move, the fibula can only move in one plane, it's hard to malreduce it. When you have more instability where the posterior syndesmotic ligament is injured and you're getting a lot of movement, then that's where the clamping or trying to reduce the fibula may move a little bit more anteriorly or posteriorly. So in those cases that are more unstable, it's important if you're going to use a reduction clamp, which many surgeons use, that the reduction clamp goes in the line of the syndesmosis, which is kind of from the posterior half of the fibula to the anterior half of the tibia. If you put it directly across, you tend to get some posterior subluxation of the fibula. And that's been well documented in many papers. And there's a couple of biomechanical papers and cadavers that actually show that and were performed at University of Iowa, which I think really demonstrate that if you apply a clamp, you should apply it in that direction to avoid the malreduction. Now, with that said, even if you do get a little bit of malreduction, it's also been shown that if you use flexible fixation, it does have a little bit of forgiveness that it'll go back to the reduced position. So
It's good to know.
even if
That's a
you
plus.
technically challenge, you can still get a good result.
Those are all great points. And, once you're comfortable with the technique, the question really becomes how much fixation is enough. So as far as using 1 versus 2 tight ropes, how do you make that decision, Ned?
Well, generally speaking, I think if you're treating an athlete, high-level individual, and they're going back to high-level activity, I think it's, as a surgeon, just feels better to use 2 tight ropes versus 1. Again, you've got 2 points, 2 anchors of fixation. You got, less inability to, for the fibula to move excessively. Sure. And I think adding a second suture button really doesn't add anything to the recovery. Right. And I think it actually makes it a little bit more stable. So I think you're much more amenable to more aggressive physical therapy and rehab.
Yeah. So biomechanically, this sounds great. More physiologic motion, that just makes more sense than screw fixation. But there's still a lot of surgeons out there that like screw fixation. So what do you tell them in terms of patient outcomes, in terms of ability to return to play, timeline for return to play, or patient outcomes with use of the TightRope compared to the screws?
Well, I think the key is to get anatomic reduction and get the syndesmosis healed in a good position. So screw fixation is fine. I mean, you can use screws, but in my opinion, I think they should be removed, at 6 or 8 weeks, maybe 3 months at the latest, and then rehab after screw removal. Now, I think there's some situations where even after screw removal, there's risk of widening. So, for example, you have pes planus or pes planovalgus. They start weight bearing and they start pushing the fibula outwards. Then I think there's a risk of getting some widening of the syndesmosis. So I would say after screw removal, you already got the screw holes there. You might as well put some suture buttons there for the rehabilitation portion.
Yeah, I like that. Yeah. Well, technology continues to evolve, as with everything, and this brings us to a newer system, so the TightRope Pro. Can you tell us a little bit about this and what your findings thus far?
Well, the TightRope continues to improve, continues to evolve, from the beginning until now. And one of the concerns with the current TightRope, not the new version, is really the size of the drill hole. So, there's always a concern for a stress riser from the 3.7 millimeter drill hole. And so I think if you can minimize that risk, and we minimize it by putting a plate, on the lateral side to kind of share the load and avoid the stress riser effect of the drill hole in the fibula. So the new device is basically a smaller drill hole, which I think is one of the most important points. I think it reduces the likelihood of, we've had the occasional stress fracture through one of the drill holes. And it happens with screws and everything else. But I think that is really probably the most important advance with the new TightRope Pro. The other thing, it makes it easy to tension the TightRope, with the new handles and retension as necessary. So I think it just makes it a lot easier. You can actually have the arthroscope in the joint while you're looking at the reduction and the tensioning. So it's a much easier procedure, and I think it's a big advance, mostly because of the reduced risk of the stress riser from the drill hole.
That's great. So we wrap up on the show always with the discussion of rehab and return to play. How do you treat these athletes after surgery, and then how quickly can we get them back? So what does your post-op protocol look like in terms of weight bearing, range of motion, clearance for impact activities?
Well, that's always an area of controversy. Surgeons tend to be, in my mind, too conservative, because, okay, you had surgery, it's going to take you, 2 months to get back. Well, I think we should think about the pathology and how aggressive you can be. So if you take these cases that we're talking about, a lot of doctors will treat them conservatively, and these athletes will get back to functioning, weight bearing. They're pretty stable. They're just not perfectly stable. So here you're taking something that's pretty stable. You're going to do a surgery that's going to make them completely stable. So why not just treat them like they're stable? In other words, treat them aggressively. So after I do this surgery, generally, I let them weight bear right away. I do range of motion, get the incisions healed for the first couple of weeks, and then progress their strengthening and progress their activity. So, you hear these cases like, the Alabama quarterback that went back and played. I think that's the type of approach we should take, depending on the pathology. Now, if you have a deltoid injury and they need that repaired, then you're going to be a little bit more careful. So it kind of depends, the rehab on the pathology that you're treating. So if you're kind of the isolated syndesmotic injury, it's the anterior tib fib ligament, there's not a lot of instability, I tend to be very aggressive and rehab and progress is tolerated. If they have more than that, then we, take a little bit more cautiously, probably let things heal. So if they have a posterior injury or they have a deltoid injury association, probably 6 weeks of healing, where they probably do range of motion, reduce swelling, just get the ankle ready for loading at 6 weeks. And so then from 6 weeks on, do the strengthening and progression after that.
That's great.
Yeah, and it sounds like a lot of what we do, it's often an art of trying to figure out if they're ready to return to play, because you're thinking about where are they, in their spectrum of play. Are they collegiate? Are they professional? Is this a kid? And so it sounds like you're taking an individual approach to everybody.
Well, you guys are really in the know. You're asking all the appropriate questions for syndesmotic injury. So I assume you guys knew all the answers anyway, so I didn't add anything to the equation.
No, we appreciate it. We appreciate you joining us.
Yeah.
So thank you so much for joining us today. As we just said, it's been a fantastic discussion. We really appreciate you taking the time. And thank you for listening to this episode of the Sports Docs Podcast, live from the Arthrex Team Physician Controversy Conference. We hope you enjoyed our discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine.